Call us back in session. We'll pick up where we left off. We were in the question section. So if you had some people that represented that wanted to come to the table.
Secretary Gillespie and Dennis Smith, both with DHS.
Mr. Smith, if you would introduce yourself and who you represent for the record.
Dennis Smith, Senior Advisor, Department of Human Services. Thank you.
Thank you. All right. Representative Gonzalez is not here yet. Representative Boyd, you're recognized for a question.
Thank you, Mr. Chair. I just wanted to start with discussion on the marketplace, on the insurance marketplace. That was originally when we passed, not we, because I wasn't in the legislature, but when the legislature passed the private option, then we, when I was there, became Arkansas Works. There was a lot of discussion about stabilizing the marketplace, keeping insurance costs down. Now, as I understand it, we really only have 2 carriers in the marketplace, so that doesn't, show a lot of competition, and rates are rising. So why should we support this if that's the case? Help me understand what's going on in the marketplace from your view. Thank you.
Thank you, Representative Boyd. We've now had the marketplace for 7 years now, so our market is very stable. Other states that had tried to do a premium assistance previously, New Hampshire and Iowa, had tried that. They were failures from the beginning because they didn't have sufficient volume in their marketplaces versus what we have here in Arkansas. So we actually have one of the lower premiums in the country. We are well below where Iowa is now over $800 premiums. New Hampshire is slightly above us. We are lower, our premiums are lower than our surrounding states. So again, the economics of what makes market works is sufficient volume and stability, and I think we've achieved that.
So I've got a kind of a follow-up, kind of a separate question. So as we've discussed this, why, again, we have traditional Medicaid, which is still in place, where we're not paying, in essence, profit to the carriers. Why do we not just figure out, because we have a lot of purchasing power, we should be able to create a lot of efficiencies as a government. Why do we need to involve the carriers when we could just expand into traditional Medicaid? How do you answer that?
I think our traditional Medicaid, one of the original reasons for going to private health insurance plans was to provide more timely access, especially to our specialty providers. In traditional Medicaid, you have to raise the rates for all of the providers. You cannot just pick and choose in fee-for-service between what you're going to pay a doctor. We do pay higher, the QHPs do pay higher rates, 25 to 65% more than Medicaid fee-for-service does. If we were to return everyone to fee-for-service and to have the same timely access as we do now, the rates would have to be raised not just in our Arkansas Works, but for the entire Medicaid program, and that would be extremely costly. The carriers themselves also provide part of the match rate. They pay a premium tax that is worth about $160 million that we can use for state match rather than general funds. And overall, when you look at not just the spending of what comes out from the Medicaid budget, but also when you look at what revenue is brought back into the state, that, again, there's what's called a multiplier effect. So as dollars get spread out through the system, we actually then collect a higher amount of revenue, not just at the state level, but the local level as well. So on balance, our proposal, the Our Home proposal, is $130 million better than a fee-for-service option.
Yeah, you can have follow-up.
So I'm a little slow right now. It's been a long day. So you just told me, if I understood, that by going with the qualified health plans, your math shows $130 million less than if we went whole hog traditional Medicaid?
130 million better than compared. So when you look at the spending and the revenue that comes in, we would spend less in fee-for-service, but we generate more revenue through the QHP model. So on balance, we are $130 million better than fee-for-service when you're counting spending and revenue.
May oblige me with
I got other people. I'll put you at the bottom. Representative Dotson, you're recognized for a question.
Thank you, Mr. Chair. Trying to wrap my brain around that math. I didn't follow that at all. Let me go through. So how much more will this cost in total than the fee-for-service, both federal and state?
So we're looking at a 5-year waiver, so these are 5-year numbers.
Okay.
Our assumption is we negotiate with the federal government a trend rate that grows every year. The current trend rate grows 4.7% per year on a per member per month basis. Our home proposal brings that more to 4%. So total spending will go slower than under the current waiver.
We're not talking about the current waiver, though. We're talking about moving forward. So
yes, sir. So moving forward, the state share, the revenue from the federal government is $9.8 billion for our home. Under fee-for-service, the federal money coming into the state would be $3 billion less, $6.8 billion. That's what on the federal side. On the state side, our home would spend $931 million. Fee-for-service, we would spend $751 million. So that is less spending. However, when you look at the multiplier effect of the dollars, as dollars churn through the economy, we would bring in, the fee-for-service would bring in $310 million less in revenue compared to the Our Home proposal. So spending is lower, but there's also $310 million less in revenue. So on balance, when you look at spending and revenue together, the difference is $130 million in favor of the Our Home proposal.
okay, follow up.
Yeah, you got to follow.
So if my math was correct in this, from what you were saying, total taxpayer spend is going to be about $3.2 billion more under Our Home than fee-for-service. However, you said there's $300 million that we will be saving.
Forfeiting, correct. Yes.
Forfeiting. So it's really $2.9 billion more for Our Home than fee-for-service.
So
Total taxpayer spend, federal and state, $2.9 billion additional.
when you are looking at the total cost, yes, the total cost is more in qualified health plans.
Okay.
They are more because commercial rate, the QHPs are paying their providers commercial rates, which are 25 to 65% more than what we would pay in Medicaid fee-for-service. So those providers, if you go back the other way, then you are asking the providers to forfeit that additional funding.
Okay,
And
I've got more, but I'll jump back in the queue.
Well, also, I'd like to answer that too, just a little bit to tell you. So we've had 57 hospital closures in all the states surrounding us that did not expand Medicaid in this way, and we've had one closure in the state of Arkansas in the last 10 years. I think a lot of that has to do with expanding the population, the Medicaid population, in the way that we did. I was opposed to this, and I think you know that. I was opposed to this early on. I got on the healthcare task force. I figured out exactly how the money was coming into the state. The feds cut us. They cut, because I work for a hospital. The feds cut our reimbursement rates. They called it sequestration fees, right? So we got cut in all these different areas, and they essentially said, we're taking the money from here. You want it back? You participate this way. And that's what the state of Arkansas did, was participate that way to get that money back. We also lost uncompensated care in the hospital system. There's no other way to get that than through a model like this. And so what I'm afraid of is, I live in rural Arkansas, which I know a lot of us do. If we don't pass something like this, or we end up straight fee for service with much, much lower rates, I know I can promise you my hospital in Izzard County, it's on the brink of closing anyhow, will close. It will happen. They're on the brink anyhow. And so for me, that's one of the biggest things with this, is making sure that our rural hospitals stay open. As in, it's in the handout that was given out to you guys too, that you can see how the hospitals, it's on page 8, but you can see all the hospitals all around us that have closed in the last 9-10 years, and just one in South Arkansas. So anyways, it is more federal dollars. It is. I agree.
Yeah, committee, you should have the handout that was put on your desk while we were gone. So, all right, Representative Cloud, you're recognized for a question.
Thank you, Mr. Chairman. When we got interrupted, we had a couple of words that I really like to hear: accountability. So if you guys would help me understand, Arkansas Works, we've had no work requirement for the last 2 years. And then also, and I don't know the numbers, but I'm sure y'all probably do, there was supposed to be, the governor used the term a little skin in the game, where those recipients were supposed to pay a small amount back in, $10, $12, if I remember right, something like that, but there was just a pitiful percentage of that was actually collected. So now we're going to negotiate, I believe you said, with the federal government. So help me have some reassurance that this process is going to be so much better than Arkansas Works. Thank you.
So under the Our Home proposal, we will have more people with skin in the game than we do in the current model. Currently, people below 100% of poverty pay nothing whatsoever. Only those above 100% of poverty have been charged a modest $13 a month. And if the carriers do not collect that themselves, then the state has the ability to do a tax intercept to collect if somebody is paying taxes. But the vast majority of the population is below 100%, and they pay nothing. So we pay the carriers the premium, and we pay cost-sharing reductions. So because people are not required to pay anything, when they go to the doctor, when they go to the pharmacy, they pay nothing whatsoever. So the neighbor is paying for them on their behalf when they go there. Under this proposal, everybody will have cost-sharing applicable to them. So there are specific dollar amounts, and this is why we think even the Biden administration will approve it, because these are amounts that are allowable under federal law for Medicaid. There's specific dollar amounts, and there's an overall 5% of household income cap. So somebody who hits that cap then doesn't pay any more cost sharing, any more copayment for the rest of that quarter. But then that quarter starts all over again. So there is much more serious skin in the game in this proposal than in the past.
And if I could add, we're changing the way it's collected. We will not make the carriers whole if they don't collect it. So we're not going to be going after the fact through a tax intercept. it is on the insurance companies to collect it.
Representative Gonzalez, you're recognized for a question.
Yeah, I didn't know how to question, but yeah, thanks. I do now. Okay. The tax intercept, how many times has that been used, and what is the percentage of people who actually participate without that? Do we have good participation in that without using the tax intercept? And if not, do we use the tax intercept?
Yes, we do use the tax intercept. We send a notice. The carriers send a monthly bill basically to everyone to pay their premium. And at the end of the year, those who have not paid all the premiums, they send that to us. We send them a letter that basically says, if you don't pay by X date, we are going to turn it over to DF&A to collect through your taxes. And then DF&A does. And I'm not sure if Dawn has exact percentages. You are right. I mean, in general, it is not a large percentage that pay all of it, but there is a significant percentage that do or pay most of it. We get, with that last, we're about to collect and turn you over to DF&A, we do get people who then pay us, and then DF&A has been collecting over $1 million annually through that process.
So as a whole, what percentage of what's owed to the state do we actually recover?
I'm looking to see if Dawn knows this. Is she behind this pillar? Okay. So, oh, she's to my left.
I have the amounts, not the percentages. Sorry, if you give me a second.
Okay.
I'll give you the numbers, then we can do the percentage. So, for
Excuse me, you need to come to the table and introduce yourself before you give information. Please introduce yourself and who you represent.
Dawn Staley, DHS.
You're recognized.
Thank you. So because as Secretary Gillespie said, we have to wait for the year to end, send the letters, and then collect it. So we're always in the arrears in terms of being able to collect against prior year's payments. But we had $4.8 million that was due from the 2017 plan year, which resulted in a total of $3.9 million in unpaid premiums. And then of that, we collected thus far $1.6 million.
So again, this is what's different going forward than in the past. If someone didn't pay their premium, that was up to the state to collect it. That's not going to be the case in our home. The QHPs now are going to have a greater interest in making certain their members pay the premium to them. Because if they don't collect the premium, that's out of their pocket, not the taxpayer any longer. If someone doesn't pay their cost sharing, that's not out of the taxpayer pocket anymore. So this is a fundamental change to make certain that these, in fact, are personal obligations, no longer the obligation of the taxpayer to make the QHP whole. So if they don't collect their premium, then they are out of that is their.
Could I have a follow-up, Mr. Chair?
One follow-up.
Thank you. So we've done all these things to expand access to care in Arkansas, supposedly to expand access to care with the Arkansas Works and private option. We've given people health insurance. We're still next to last in healthcare outcomes in the state. How can we be assured that this program is going to improve healthcare outcomes and not just continue paying health insurance for these people?
We agree with you, and that's why one of the elements we worked into this is on the accountability line is that every year as part of our purchasing agreement with the QHPs, it will include health improvement targets that they have to meet in the next year. We have included in the law the ability for us to assess penalties, including financial penalties, against the QHPs if they do not. And then to ensure that there is very public transparency around all of that, we are proposing in there to create, and this was actually suggested to us by some legislators during our meetings, to create an accountability and oversight panel that is part legislative, part executive branch, and then some individuals from the general public that will review quarterly what is going on in terms of both health performance, economic independence performance, and Life 360 home performance. So throughout the course of this 5 years, we intend to be measuring all of this, but also not to have it where just DHS is looking at it, to where we have a broader group looking at it. And if this happens, it would start this summer with the setting of the targets for next year. And that panel will be part of the review of what those targets should be.
Just real quick.
We'll put you at the bottom of the list.
Well,
I
and I,
promise it's directly related to this.
All right.
Fast.
You're
So
recognized.
is that part of this legislation, or is that something part of the rules that are?
No, it's part of the
Okay, all right.
legislation.
it is, and I also want to say, too, one of the things that I added after a meeting with Senator Flippo was, it's on page 9, but let's see here. Line 27 on page 9, if the Department of Human Services determines that the individual QHPs have not met the quality and health performance target for 2 years, the Department of Human Services shall develop additional reforms to achieve the quality and health performance targets. So that was one of the things. And then also, DHS may take the action to Legislative Council or Executive Subcommittee for immediate action. And I'll tell you, too, Senator, I don't remember who filed, I think it was Senator Sullivan, and maybe, I don't know if it was Representative Miller, I can't remember who did it in the House, but they've also got a bill that will bring, I think monthly reports to ALC or Public Health, something like that, so that we can measure this from a legislative. I'm fine with that. I think that's a great idea, too, just so we can track the outcomes, because I agree with you that we need to track that.
Representative Miller, you're recognized for a question.
Thank you, Mr. Chair. We've had several meetings and talked about this, and I appreciate y'all's good temperament. But this is go time, for lack of a better word. And what I mean, I've heard a lot of things said. I mean, basically, I don't understand why we're not just spending $8 trillion a year in QHPs because they're so great for the economy. I mean, listening to this logic, why? My first question is, why are we still the only state that does this?
I think we're the only state that still does it because it's working here in Arkansas. The two states that tried premium assistance previously, one was Iowa, the other was New Hampshire. Iowa included only those above 100% of poverty instead of their entire expansion population. They didn't have enough bodies to make it economically. They also, their largest insurer, Blue Cross, did not participate. Their other plan was a co-op plan that came out of the ACA legislation itself. That co-op had no experience in running a health insurance company. They collapsed almost immediately. They ended premium assistance. They put everybody into a managed care plan. In New Hampshire, they tried premium assistance also. Their churn rate was over 50% because in New Hampshire, people were getting out of poverty and getting out of 138% poverty level so quickly. Again, their market was unstable. This isn't a matter of, it's a matter of economics, right? Economically, neither one of those states could make it work because of the choices that they made. Instead, we have sufficient volume. We had experienced carriers who know how to make health insurance work. I think the other thing about premium assistance is something that when you look at different groups, when they talk about Medicaid reform, if you look at the Heritage Foundation, if you look at the Galen Institute, if you look at all of these policy think tanks, they're saying put people in premium assistance, put them in private coverage, not fee-for-service Medicaid.
Again, and I appreciate the response. You told us why Iowa and New Hampshire failed. There's 47 other states. I don't know of anybody else that's even trying it. And I know there may be some think tanks, probably those that are funded by the insurance companies, who are making a healthy profit on this program, that obviously are promoting it. But I'm just saying, we've been dealing with Medicaid expansion as a country for 10 years now.
Yes, sir. So,
and we're the only one doing it. And I'm still like, why aren't other states looking around and saying, boy, Arkansas, this is working fabulous.
the
Let's go
other,
be like them.
I'm sorry. The other states are not putting their population into fee-for-service either. They're putting them into managed care plans. So when you look at the other states that did Medicaid expansions, they had their history in Medicaid for 10, 20 years is Medicaid managed care. So many insurance companies that offer products in Medicaid managed care and in private insurance, they don't want to mix their business. So the Medicaid managed care side of the house, when you look at these large national companies, the Medicaid managed care side of the house got the business instead of going over to the commercial side. But those other states are not, they don't have their adults in fee-for-service. They have them in managed care, and those managed care plans want, the Medicaid managed care plans want to keep them in there instead of in the, on the commercial insurance.
I just want to make sure I'm clear on what you're saying. All other states who have expanded Medicaid do not have their populations in fee-for-service. They have them in managed care, every single one of them.
I will go back and check to be absolutely certain, but not a single state comes to mind that is in fee-for-service.
Okay.
And I can tell you too, Representative Miller, that I know when I was on the healthcare task force that Arkansas, we only covered at the time up to 17% of federal poverty level before we did this. And there were other states that were up to the 100, that were over 100 or 138. So there was nothing to expand for them, right? So we had a lot of expansion to do where they had nothing to expand. So I just wanted to throw that out there as well.
Thank you, Mr. Chair.
Representative Boyd, you're recognized.
Thank you, Mr. Chair. So anyhow, never mind. I'm going to.
Representative Dodson, you're recognized for a question.
Thank you, Mr. Chair. So I think you've covered a couple of my questions. I guess the question is, under your new proposed Our Homes plan, how many more people will be covered under it than what is currently covered today?
So the adult population 19 to 64, we are currently around 300,000 individuals. So how many more become eligible is really dependent on the economy. The stronger, again, Medicaid is means tested. It's measured by federal poverty level. So in a strong economy, if people are, so a lot of people are working even below 100%, but they are what we would consider underemployed. They're not working full-time, full year. Full-time, full year is 2,080 hours a year. If with the minimum wage increase that went up to $11 an hour, if you work full-time, full year, you will not be eligible for this program because you'll make too much money.
So you anticipate there being a reduction in the number of people who qualify?
It will depend in large part on the economy. Right now, we cannot disenroll people because of the federal law on the COVID legislation. So we have to keep people in the program, but that will end at some point in time. So when that does happen, the enrollment will likely go down.
To be very clear, we are not changing eligibility. The eligibility is set, and it was set when private option was established. It stayed the same through Arkansas Works, and it stays the same with this. So the same age group and income groups are eligible. Our goal with this is to get more people educated, skills, moving up the ladder, and off the program. But that would happen naturally because they would not be eligible anymore.
As a follow-up, as I understand it, you're expanding the carrots to enroll.
No, sir. No, sir, not at all. No, it is the same program with the same health care coverage, right, that exists today that people sign up with.
No additional services?
No additional services. The QHPs, and in fact, when you think about it, putting cost sharing on it is actually, right now, we have cost sharing on children in Medicaid. We don't have cost sharing on these adults below 100%, right? So they will have copays and cost sharing that they don't have today. But the QHPs, one of the things that we're trying to do with the QHPs is to get more value out of using QHPs. And so we're bringing the QHPs in both through accountability measures and through allowing them to do incentives so that they have to drive health improvement, meet health improvement targets and drive health improvement every year, right? And then in addition to that, they have to be partners with us in trying to promote economic independence among the population. So for that reason, yes, there would be more value to being in it, but it's not like by being in this plan, it's going to pay for your housing or something like that, right? You're still getting, your doctor is still getting paid through the plan is what's happening. Does that make sense?
Thank you.
Thanks.
Representative Eubanks, you're recognized. That's right.
Thank you, Mr. Chair. I'm curious how these 300,000 people that are on private insurance, how that affects the overall insurance market for the state, to all the other citizens of the state.
We can obviously let others that know insurance better discuss this, but what I would say is this: they influence the market they're in, not the entire insurance market. So there's somewhere between 50 and 60,000 people who are not in Arkansas Works, but are purchasing plans through the marketplace. And so what happens is by putting all of these additional lives in there and purchasing plans in that marketplace, it makes the risk pool much larger in there. And so for the 50 to 60,000, what they were talking about is that it provided more stability than in other states and helped to keep our premiums at this point lower than surrounding states.
Thank you.
Representative Bentley, you're recognized.
Thank you, Chairman. First off, how much of the $9.76 billion that we're paying to the QHPs, how much are they able to keep for profit?
So again, that figures over a 5-year period of time. Mm-hmm. Each year, we are about roughly 1.8 billion to 2 billion, but the premium is what they get, right? They get to keep their, when they pay out cost sharing to provider, that goes out and gets paid to a provider. We pay about $300 million in the fee for service. We pay about $330 some million on cost sharing. So the premium amount, they have to meet a medical loss ratio of 80%. That's what is in the Affordable Care Act. So we follow that 80% medical loss ratio. Out of that, so the 80% is on the medical benefits. Mm-hmm. The other 20% is the cost of running the business. The cost, so part of that is the provider tax that comes back to us. That comes out of the 20%, et cetera. So when you do the cost of the operations, the premium taxes, et cetera, the margins of what they keep as profit, I don't know that amount.
But if I could, just to add on to it, the MLRs that are reported in terms of what they had to spend, as he said, on the medical side, what we have seen is that year after year, one of the carriers is up in the 90% every year, over 90%, up to 95%. So that doesn't leave a lot for the administrative cost on the other side, or the 2.5% that is paid back as premium tax. So,
Okay.
No, and that we do not pay the $9 billion to the QHPs. I mean, part of what he was saying is that out of the $1.8 billion every year, about 1.1 to 1.2 is actually what is flowing through to the QHPs, and it is off of that 1.2 that you look at the medical loss ratio. So it is not as large as it appears.
Follow up on that. What percentage of the people that are receiving these the health care benefits that are not using them at all? Do we have an amount of, we're paying for their health insurance every month and they're not utilizing it all? Do we have a percentage on how many of those are not being utilized?
Yeah, it varies, again, by age, by all number of different variables. Remember, it is insurance, mm-hmm. So you expect to have people who don't have claims.
Right.
And then the number of people with 0 claims, the number between 0 and 5 claims, 15 or more claims in a year. So when you're looking at when you look at employer-sponsored health insurance as an example, and we have not gone back into the QHPs, so again, just by reference, there are studies out there that generally 30 to 40% of people don't have claims in a year. But again, it's those people who are not using it that offset the cost of the people who are, use a lot of medical services. So the percentage that are low users and the percentage that are high users is generally about the same.
One real fast, and I'll let you go on to someone else, but give me some real quick details on this maternal homes, because I know I should have visited, but just give me a real brief overview, real quick, how we're going to improve our maternal mortality morbidity rates through this.
Right. So the maternal or home, the concept is that hospitals in the state, birthing hospitals in the state, basically become an anchor. And what we will do is for women in our home, right, who have high-risk pregnancies, which statistics, what we've seen in previous years, it runs about 5,000 women a year, would be eligible for that hospital to provide for them through either the hospital or a local partner in that county intensive home visiting services. And those intensive home visiting services would start while she is pregnant to help focus on getting through a good pregnancy, right, and hopefully a healthier birth, and then continue for up to 2 years after to help ensure that both the mom and the baby are healthy through that period. So it is taking some models, some of which are already in Arkansas and some which are nationally approved, and basically finding a way to put those where we have somebody literally going into the home and working with the mom-to-be or the new mom.
Thank you.
Representative Payton, you're recognized for a question.
Thank you, Mr. Chair. So earlier before the break, we were discussing the incentives or penalties, depending on which side you're on, for living a healthy lifestyle, doing the things we think would improve your health and lower the risk, which is lowering the risk for the insurance companies that we're purchasing the insurance from. But in that discussion, you mentioned that people not following the prescription might be moved to fee-for-service. And I know we already have medically frail population that we protect the insurance companies from covering them. So it seems like we're underwriting the insurance companies to make sure they don't have the losses, which I know when we started this private option, there was a trigger that if they hit $550 a month per member per month, that it would kill the whole program. So there was a lot of incentive to, we had people that didn't exist on there to drive the per member per month down. So can you tell me today how many people who are part of the expansion are currently on fee for service because they're medically frail or because we're trying to keep those losses off the insurance company?
There are about 22,000 medically frail, and that stays pretty constant over time. There are people who are temporarily in fee-for-service. They've just been found to be newly eligible. They wait a short period of time in fee-for-service before they move to the qualified health plan. That's about 26 to 28,000 people.
So I need to follow up?
Yes, you got to follow up.
So the 22,000 that are medically frail, and then with the guidelines we were talking about earlier of others that we may move for other reasons, have you done a projection on how many we're talking about that we would be pulling? And is that, am I misinterpreting the fact that, these are the high loss, high risk, more expensive healthcare field or what?
Let me make sure I correct something with you first, and then we can get to the second part of that. In fact, what we're talking about in terms of people who don't use their plan, right, would be people who over a significant period of time are not using their plan in any way and are not showing that they're moving towards economic independence. So from your question you're asking, those would be people, therefore, who aren't showing any claims, right? So it wouldn't be the high-cost people. It would be the people who don't cost the carriers anything that the carriers would be at risk of losing into fee-for-service. So their incentive would be to get those individuals doing something, right? Actually moving up that income ladder, getting across certain thresholds, or taking advantage of things versus just being on the QHP. So I did want to correct that part. If you want to answer the other part of his question.
Well, no, while we're on that correction, so you're saying that if somebody's not following the prescribed safety measures or the incentives that is going to help them live a healthier lifestyle, if they're not following that and they have losses and claims, that we would not move them?
They would stay in the QHP. If you're having medical claims and you are using your insurance, you stay with your insurance. Even if
you're failing to meet the incentives?
The incentives are about creating opportunities for healthier improvement. And so the QHPs will be required to provide incentives both on health improvement and on economic independence. If someone doesn't avail themselves of either of those, then they miss out on the incentive. But if they have medical claims, they still stay in the QHP.
Thank you. Thank you, Mr. Chair.
Representative Miller, you're recognized for a question.
Thank you, Mr. Chair. Mr. Smith, earlier you were talking about, the comparison between if we went fee-for-service as opposed to using the QHPs or the insurance companies. And you brought up the word revenue quite a bit in that we save money as a state and as a government. We save taxpayer money if we go the route of fee-for-service, but we lose revenue by not going the route of the insurance companies. Who's getting the revenue? Whose revenue is this that you're talking about?
So it would generate less revenue. It still generates revenue, but it's a lesser amount. And DF&A built this off of a business development model on how to model what the revenues are. The revenues go to local government and to the state government. Part of it is an income tax, part of it is sales tax, so there are other kinds of taxes on so the local government may be getting, will get part of this tax revenue, and so then it shows up on the state revenue side as well.
So you're talking about the just the additional tax revenue that we see coming back in is to the tune of 100, and I think you had told me one time, 130 million over 5 years more.
It's 180 million better than fee-for-service. I'm sorry, it's $300 million better than fee-for-service. But since the state spending, when you are netting it out on the spending side, because we spend less on fee-for-service, but fee-for-service also brings in less revenue. So when you count the spending and the revenue, the state is better off with the QHP model because we generate more revenue under that model to state and local budgets.
Can I have a follow-up, Mr. Chair?
One more follow-up.
Thank you. So with that being the case, why do we not do all of Medicaid under this same model?
Because the state still has to come up with its share. The federal government will send money to us only if we come up with our share. And we're competing, our home has to compete against everything other budget priority in the state budget, right? So again, that's why we are saying it is, we think, the better model, but even that has some constraints. We can't just take every dime and put it into our home.
Right, exactly. Thank you, Mr. Chair.
Representative Wing, you're recognized for a question.
Thank you, Mr. Chair. So we've heard a lot of questions getting into some of the specifics of this bill, and it's a very complex issue. Sometimes it helps us refine our argument if we step up and take an overhead view again. So I'd like to ask a question of, when I got onto this committee, I wanted to increase access to health care, and I wanted to lower the cost of health care. How does this bill help accomplish both of those goals? Kind of an elevator pitch opportunity here.
Sure. And if you give me an elevator pitch, I will take it. So what this bill does is it increases access in that those who are in our home, the evaluations that have been done by ACI and others show that those who are in our home have faster access to health care services, right? So they are more quickly able to see a specialist. They are more quickly able to get a doctor's appointment than someone in traditional fee-for-service Medicaid. It also helps with access because of the point Representative Gray was made. Other states around us have wound up with their rural hospitals closing. And I know we have some hospital CEOs who are here today that will talk to you about the impact if they lose this, if they lose the additional rates money that they receive through the QHPs. So that keeps our access in place, helps them to continue to grow and improve what's in this state. There's significant difference between where we were 7 years ago and where we are today. And it does provide faster access. Our goal around cost is twofold. One, we are slowing the growth in cost. We will negotiate with CMS a trend line for how much this can grow that will be below the current trend line. That creates that cap that every year we can't go above. If we go above that as a state, then we go to 100% state spending. and that y'all will kill us. I mean, that it is a cap. And so we have also said in the legislation that the QHPs must also abide by that cap every year. If for some reason they are above that amount, we will not reimburse them. We will not pay them. So we are putting some measures in place to hold ourselves at that slower growth cap. And then the third point on that is, at the end of the day, the way you reduce healthcare costs ultimately is to get a healthier population. And that's why we put in a real plan for not just requiring health improvement on the population, but real-time tracking it with y'all so that we can keep moving towards it, and penalties if they are not, if they're not improving health.
Thank you.
Representative Wardlaw, you're recognized for a motion.
Motion to call the question.
You mean do pass? Make a motion do pass?
I make a motion to pass.
You have a second motion? Immediate consideration.
I can't do that because it's not proper. I would make a motion to call the question.
Okay. All right, we have a motion, call the question. Not debatable. All in favor signify by saying aye. Aye. All opposed, nay. No. I'm going to say the ayes have it. Roll call. Okay. Roll call.
This way or this way? Okay.
Representative Wardlaw.
Yes.
Representative Eubanks.
Yes.
Representative McGee.
Yes.
Representative Dodson. Representative Dodson. Representative Miller. Representative Payton.
No.
Representative Bentley. No.
No.
Representative Gray. Representative Gonzalez.
No.
Representative Boyd.
Yes.
Representative Allen.
Yes.
Representative Coleman.
Yes.
Representative Pilkington. Representative Pilkington.
Yes.
Yes. Representative Wing. Yes. Representative Penzo.
No.
No. Representative Perry. Yes. Representative Marsh Davis. Representative Marsh Davis. Representative Cloud. No. Vice Chair Ferguson.
Yes.
Chair Ladyman.
Yes.
Yes. 2, 3, 4, 5, 6, 7, 8, 11, 12. 3, 4, 5, 6. 12 to 6. So, well, there's 19 is here. 2/3 of 19 is 13, right? I think it takes 13 votes.
Motion for immediate question fails. All right. We have no further questions on the list. Representative Gonzalez, you have a question? You're recognized.
Thank you, Mr. Chair. So managed care has been brought up a few times now. And I know insurance companies use a managed care model, basically. I mean, we all have to do prior auths and stuff, and they have to do this through the Arkansas Works program as well, I'm sure. So how are we better off paying insurance companies to do that versus just flat out hiring a managed care company to come in and manage our cost.
Okay. So, managed care is a culture, and Arkansas does not have that culture here. In states that have expanded managed care, they started it back in the 70s. They did it in the 80s. They didn't do it statewide, and those that did try to do it statewide basically failed. You start small, and then you expand from there. But managed care, to me, again, is a culture. Medicaid cannot bring that culture by itself. It has to, the doctors, the hospitals, the beneficiaries themselves all have to be comfortable with that model to actually work. And I don't think that is here in Arkansas. I've been in states in which I did have managed care companies. I did it in Virginia. I started it small and grew it. It took 20 years to get as big as it is today. You don't do it all at once. If you do try to do it all at once, it fails miserably, and your constituents will be calling you 3 times a day, every day of the week. Your doctors will, everybody. Managed care is managing to a contract. If you look at a Medicaid managed care contract, those are 400 to 1,200 pages long. And that managed care company is managing to that contract. If you didn't say you have to report this every month, they're going to say it wasn't in the contract. If you ask them to do something else, they're going to say it's not in the contract. Managed care is a culture, and I don't think Arkansas is ready to do that statewide for 300,000 people and the doctors and the hospitals and everybody else.
Follow up? Yes, thank you. So I'm not real sure that answered my question. So, I don't deny what you're saying. That's fine. Arkansas may not be ready for managed care, but just on a pure cost basis, what are we looking at, and why are we better off paying insurance companies to do this?
Again, managed care companies are looking to where you overpaid on the fee-for-service side. They are looking to get inefficiencies out. They are, and they're managing tighter utilization and lower provider rates, quite frankly.
I think what he's asking is what's the cost to the state per member per month or something like that for managed care versus this? That's what he's asking.
We did not model a managed care proposal. It would be, I don't want to just guess.
All right, any other questions from committee? Seeing Representative Pilkington, you're recognized.
Thank you. I know this debate's been going back and forth about fee-for-service. Mine actually has nothing to do with what we've been talking about. It's clearly on the AR Homes program. Can you kind of explain to me, it's very hospital-based, which is great, but can you explain to me how our local providers and clinic groups work with the AR Homes model? Because I'm confused in where they connect. Can you explain that to me?
Remember that the bulk of this is continuing what is right now, all right? So just like right now, they work with the QHPs, they have agreements, they get paid. That's still going on, right? Still those rates, still that. When you look at the Life 360 homes, which is, I think, where you're focused, part of what we'll be working our way through is with the hospitals and with the providers. Simple question: maternal or home? How do we get those who are seeing a high-risk mom to refer that mom in for these additional services? So over the next couple, if our home comes into being, part of what we would be working with everyone is how does that referral take place? And if she's in an area, let's say that referral isn't naturally happening, we can work with the QHPs for the QHPs to go through the claims and identify that mom and perhaps reach out then to her providers, right? And try to get them to refer her for these services. So part of that will be how those connections take place between the anchor hospital, which is where you can get referred for the service, but it's not disconnecting in any way, shape, or form the mom-to-be from her provider. Her provider is still her doctor. Her provider is still the one getting everything. And our goal would be that, for example, her OBGYN would be getting the information back and forth with the person who is doing the home visiting. With one doctor, we talked about this around the Success Life home, who sees substance use disorder patients, right? I mean, she was very excited, but she said, one of the things I will want to, think through is, how do I make sure that I get the information I have about this person to the one who's going to be working with her every day in her home? Not things that shouldn't go, but just some things that she wants to make sure they know. And then how does that person get word back to me so I'm aware that there are problems arising? So that connectivity will have to happen, but that part of that is the role of the hospital in the middle to ensure that connection on the medical side.
All right, any other questions?
That's how we want the communication to happen, and that's why we keep stressing this is a 5-year plan, because part of this is now to move to the design and work through how would that work. And the Life 360 homes, we know they're not going to start all over the state simultaneously. That's actually not even a good idea. We need to have a few starting, trying out these different areas and working through how a lot of this works. And then from there, other hospitals and populations take it up and keep going. So.
All right. Any other questions from committee? Seeing none. We have 2 people signed up to speak for the bill and 2 signed up to speak against the bill. So the first one we'll call is Nic Horton to speak against the bill. Please introduce yourself and who you represent.
Sure. Nic Horton with the Foundation for Government Accountability.
You're recognized.
Sorry, my handwriting is poor, Mr. Chairman.
Looked like an A to me, but anyway, you're recognized, Nic.
Thank you, sir. Thank you, Mr. Chairman and members of the committee, for the opportunity to testify today. My name is Nic Horton, and I'm the research director for the Foundation for Government Accountability. FGA is a nonprofit think tank that works in 30-plus states on healthcare, welfare, and workforce reform. But I'm also a native Arkansan and have worked on public policy in this state for the better part of a decade now. I live just outside of Conway with my wife and 2 kids, and to be honest, they're a huge reason why I'm here today, and I felt like I had to speak on this bill. Members, quite simply, the private option model has failed, and not just by a little bit, by a long shot. And just to be clear, when I say the private option, I'm referring to the specific way, as you're all familiar, in which we administer Obamacare expansion. We give able-bodied adults free private insurance plans purchased on the Obamacare exchange with Obamacare dollars at more than twice the cost of conventional Medicaid. And every major promise that private option proponents made in 2013 has failed to come to fruition. We were promised lower premiums, but premiums have more than doubled. We were promised more insurers and competition in the insurance market, but we've lost insurers. We were promised a smaller Medicaid program, that enrollment would go down, but enrollment has skyrocketed to higher levels than we've ever seen. We were promised cost savings, but DHS's own numbers show very clearly that this model has cost more than twice as much as regular Medicaid expansion. We were promised 1,000 hospital jobs. Instead, we've seen hospitals close. And just a couple years ago, right here in Little Rock, UAMS closed 600 positions. And we were promised that this model would make us a national leader in Medicaid reform. Yet the only other 2 states that even tried it have scrapped it very quickly, leaving us as the last state standing. In fact, you'd be hard-pressed to find a single promise of the private option that's come true. And at the time, before many of you were here, this concept was sold as a conservative way to expand Obamacare, because we were told by funneling billions of dollars through insurance companies, it was a free market solution. In reality, it was a political shell game, and taxpayers got left holding the bag. We added more than 300,000 able-bodied Arkansans to welfare, helped prop up Obamacare as one of the only southern states to expand Medicaid, and we made the program even more enticing and expensive. We now spend more than $7.5 billion on Medicaid in Arkansas. Before expansion, we spent just $4.5 billion. So we're well on our way to doubling the amount that we spend on Medicaid in this state in less than a decade. Nearly 30% of every dollar that we spend goes to Medicaid. And what have we gained in return? But, as you all know, this hearing is not just about relitigating the past, it's about the future. It's about what kind of Medicaid program do we want to have, and what type of culture do we want to create for future generations in our state. After failed promise upon failed promise upon failed promise, you're now being sold many of the same hopes and aspirations and being asked to double down by not just reauthorizing the private option model, but I believe making it even worse. Specifically, this proposal would expand Medicaid expansion to even more able-bodied adults who have employer-sponsored insurance. It would put state taxpayers on the hook for paying part of able-bodied adults' Obamacare subsidies after they leave Medicaid. It doesn't include any real meaningful cost controls. It doesn't provide any real cost sharing or skin in the game. Most of these able-bodied adults will pay nothing. It will initiate a large and wasteful outreach campaign that will almost certainly increase dependency. It does not include a work requirement. And based on my reading of the bill, it does not include a real trigger for if and when Congress reduces the federal match rate for expansion costs, and much more. In addition, to be just blunt about it, I believe the bill is poorly drafted. It mentions an independence initiative, as has been discussed here today, but it doesn't clearly articulate or define who will be subject to it. Perhaps because, as noted in the bill, participation will be optional. It says enrollees will receive incentives to participate, but it doesn't specify what those incentives will be or who will pay for them, although I think it's safe to assume it will be the taxpayers. The bill also gives the false impression that the department will assess medical debt to enrollees who fail to meet the work suggestion, but the bill also specifically says enrollees will not lose coverage if they fail to pay. And again, most enrollees will pay nothing, so this is really a red herring. The bill also suggests DHS may limit enrollment in private insurance plans, but it doesn't require it. It creates yet another task force to offer advice, but it doesn't give the panel any actual authority over anything. Overall, this bill places a lot of trust and hope in the best intentions of state government and big insurance companies. It gives the appearance of meaningful reform without actually accomplishing it. And I get it. I understand we don't have the same willing federal partners at CMS that we've had for the last 4 years. So this bill has been largely constructed in a way that the Biden administration will approve it. They'll probably even like it, because in many ways, it will increase dependency and keep Arkansans trapped in Medicaid. As conservatives, I think this should obviously concern us. It's frustrating that we don't have real flexibility. But rather than playing within the Obama-Biden rules and catering to them, we should act in the best interest of Arkansas. which I strongly believe would mean rejecting this bill and transitioning to conventional Medicaid expansion. Our estimates show, based on numbers from DHS, that this shift would save nearly $100 million in state funds every year. And think about what we could do with that money. By saying no to continue to line the pockets of big insurance companies, we could say yes to our teachers and give every one of them a $2,000 raise and have money left over. We could say yes to expanding broadband access, or yes to paving an untold number of miles of Arkansas roads. We could even increase reimbursement rates and reduce the waiting list for traditional Medicaid populations in Arkansas so that truly needy Arkansans can get better access to doctors. Frankly, I think all of these things would be better uses of these tax dollars than continuing down the failed path of the private option. Ultimately, I think this bill cuts against the grain of who we are as Arkansans, a people who are committed to hard work and independence. And it's not the future that I want for my home state or for my kids. And with that, I'd be happy to take any questions.
Representative Allen, you're recognized for a question.
Thank you, Mr. Chairman. I'll be very, very brief. At the beginning of your speech, you said that we had hospitals to close in the state of Arkansas. So would you please give me the names of the hospitals that actually closed in the state of Arkansas, besides UMS?
Sure, absolutely. We had 600 positions closed at UMS, as I mentioned.
Wait a minute.
We had a.
That's not hospital closing.
Sure.
UMS did not close.
Sure, that's correct.
Okay.
Again, I would point out we were promised over 1,000 new hospital jobs when the private option was passed.
No, we're talking about hospital closure.
Sure.
Okay. So what hospitals closed?
So there was a hospital in Jacksonville that closed. I don't remember the exact name of it. There was a hospital in Crittenden County that closed. There was a hospital in DeQueen that closed, as you're all well aware. UAMS, as I mentioned, has laid off 600 positions. We had Baptist Health reported back-to-back losses of $20 million and $30 million.
Actual closing. We're not talking about losing money. We're talking about hospitals that closed.
Yes, sir. I mentioned several of those as well.
Okay. Thank you.
Yes, sir.
Representative Ferguson, you're recognized for a question.
I mean, there's so much misinformation in your presentation, I don't even know where to go. First, we're having 90-10 match, not a 30. But my hospital closed before Medicaid expansion in Crittenden County. And the main reason we closed is because we were almost a full Medicaid hospital, and they couldn't afford to stay open. We now have a new hospital that is doing very well because of Medicaid expansion and the improved provider reimbursement. So, I mean, there's just so much to unwind. You've given bad information, but I won't go any further.
Any other questions? Seeing none, thank you for your comment.
Thank you, sir.
Okay, to speak for the bill, Joe Hanna. Joe Hanna, is he here? Don't see him here. Is he in the waiting room? Okay, thank you. Not there.
You may want to ask John Shelnut to come up and say something.
Okay, John Shelnut, did you want to speak on the bill? You're good? Okay. Okay, Gregory Feister to speak against the bill. Did I pronounce your name correctly?
Pretty close.
Okay, if you would introduce yourself and who you represent.
All right. Thank you, Mr. Chairman, members of the committee. Good evening. My name is Greg Pfister, and I'm a senior fellow with the Opportunity Solutions Project, and I'm here today to speak against SB 410. A couple of weeks ago, I was in Jefferson City, Missouri, to share the story of Marcus Logan with the Senate Public Health Committee. I first learned about Marcus when I read an article in the St. Louis Post-Dispatch with the headline, "In Missouri, people who can't speak and see wait in line for help." Marcus is from North St. Louis, and at the time the article was written, he was 22 years old. He has severe autism and epilepsy, nonverbal. He has to wear a diaper and a helmet in case of seizures, and he's on a waiting list for additional Medicaid coverage that would get him into a care facility with some real support. It's a sad story, and it's what happens when a state does not prioritize its most vulnerable citizens. They end up waiting in line for funds to become available. It's also a story that's not limited to Missouri, unfortunately. Here in Arkansas, there are thousands of vulnerable people that are on a similar wait list, waiting for Arkansas to find the money to help them by providing services that they desperately need and the state acknowledges that they qualify for, but can't have yet. People like Skylar Overman from Saline County. Skylar has a rare neurological disease called schizencephaly and requires constant care. She could not eat on her own, walk, go to the bathroom, or talk. If anyone were to perfectly fit into the description of a vulnerable citizen, it would be Skylar. And yet, she was on a waiting list here in Arkansas for the first 10 years of her life before finally being approved. The sad thing is that while thousands of severely disabled citizens, people like Skylar, waited at the back of the line, Arkansas found the money to enroll over 300,000 able-bodied adults into the expensive Medicaid expansion private option program. Arkansas, as was mentioned earlier, is the last state in the nation that uses an excessively expensive plan like the private option. Every other state figured out quickly that it did not financially work. In fact, according to an interim evaluation done by the Arkansas Center for Health Improvement, the private option is 98% more expensive than conventional Medicaid expansion would be. That's about twice as much money. The private option has also set up a perverse system. Able-bodied adults are given an expensive private insurance plan with taxpayer dollars, while the disabled, poor children, pregnant women, and the elderly are placed into Medicaid. And severely disabled people are put onto a waiting list for additional support for things like home and community-based services. Voting down SB 410 will not kick anyone off of Medicaid. It's not going to remove a single able-bodied adult. What it will do is end the private option and shift able-bodied adults into the same Medicaid program as Arkansas's traditional Medicaid population. The same Medicaid program that every other state that has expanded Medicaid uses at a much lower cost. Based on our estimates, it'll be about half as much money. This will end the tiered Medicaid system that Arkansas currently has, in which able-bodied adults are treated better than disabled people. By saying no to the private option, Arkansas can say yes to many other things that will actually help vulnerable citizens. With that extra money, you could pay down the Medicaid waiting list for citizens that are the most vulnerable in society. With that extra money, you could also provide things like home and community-based services for people that are developmentally and physically disabled, people like Skylar and Marcus. You could better fund nursing home facilities. You could expand home health services for seniors. And this is just to name a few. There are a lot better ways that this money could be spent to help vulnerable citizens than pouring it into private insurance programs for able-bodied adults. And with that, I'm happy to answer any questions that the committee may have.
Representative Ferguson, you're recognized.
You do realize that 700 people on our waiver plan are off the waiver list because of a 2% insurance premium tax. Because of the insurance premium tax is what's affording those people to come off the list. Do you realize that? I mean, insurance is facilitating that.
Well, I would say that if this program were allowed to expire, all of the people could be removed off the waiting list.
Not if we lost $130 million in tax revenue from the increased employment and the trickle-down economics that this produces.
Well, to that, I would say that if economic development is based on welfare, then I think we're heading down the wrong path as a state and as a nation. I think the California model has shown us that that's not the best way to approach it.
I would say it's based on providing health care to, anyway.
Representative Miller, you're recognized for a question.
I didn't have a question. I just want a different view.
All right. I think we're all there, Representative Miller. All right, any other questions? Seeing none, thank you for your comments.
Thank you, Mr. Chairman.
All right, seeing no one else signed up to speak for or against the bill, Representative, are you ready to close for your bill?
I am, Mr. Chair. Thank you so much. And I also wanted to say Sam Lind with, I think it's Baptist in Jonesboro did come down today as CEO, but due to time, he's going to let me close and let us get out of here one way or the other. So I do want to, I appreciate him driving down today. So what I'm going to do in closure, there's been a lot of good questions. Trying to figure out, I was writing as fast as I could write when Mr. Nic Horton was at the table. There were so many inaccuracies with what he said. Like, I'm not even sure where to start. He started out by saying that the private option has failed, but he didn't give like any actual reasons as to why it's failed. I mean, it's still going. We're able to fiscally sustain it. It's doing a lot of things for the state. I don't even know what to do with that. I wasn't here in 2013. I know maybe a couple of you were. You were at the dentist during one of those votes, I think. I remember that, but a few of you were. I can't say what those promises were and what they weren't. All I can tell you is what my district needs as far as my hospitals, my doctors, all my providers, what my constituents need. And also in this handout, this is one of the things I wanted to point out. It shows percentage of people who have the QHP of your adults that are not on Medicare. My counties are some of the highest in the state. So Stone County, I think, was at about 27% of the adult population is in this, is in a QHP. So I had some of the highest in the state. He was saying that hospitals closed. Only one hospital closed. That was in DeQueen. Nothing in Jacksonville closed. And to the 600 employees that UAMS laid off or fired, that was due to COVID. I had 150 at my hospital that we ended up having to let go due to COVID. I had absolutely nothing to do with the Medicaid expansion. It does not expand insurance to any groups. It's the same qualifications that we've had the entire time in order to get into the program. Talking about cost sharing, there's no cost sharing. Yes, there is cost sharing. We can't include he talked about no work requirement. I can't include the work requirement. We just got a letter from CMS last week that says your work requirement is stricken. We will not allow it. I can't put a true work requirement in this waiver. It will not be approved. 100% Biden administration will not approve it. He talked about this bill increases dependency. Nothing in this bill increases dependency. And then he was talking about we'd save $100 million a year. I'm not sure what testimony he's listening to or what we're looking at, but that's not the testimony that was given today by DHS. The testimony given today by DHS was, yes, we save a certain amount by going to straight fee-for-service, but we also lose a lot more than that, the $130 million they were talking about. We lose a lot more than that in revenue by not having this program in place. And then he said there was no mechanism in the bill if the feds changed the model from 90-10 to something lower. Yeah, it's on page 11, starts on line 1, that DHS has, what is it? It's like 120 days They shall present to the CMS plan within 30 days of the reduction, and they'll have 120 days to essentially do something to terminate the program. So that's in the bill as well. So I just close by saying I've heard a lot of inaccuracies with that. And I hope that the presentation today, I hope that with this right here, you can see that what we're doing is the best thing to keep our hospitals open, to keep access to health care for our constituents, especially the high population in my district. Just appreciate a good vote. I guess I make a motion to pass.
All right, committee, motion on the floor is do pass. Any discussion on the motion? Representative Miller, you're recognized.
Thank you, Mr. Chair. Folks, I'll try to be as brief as possible. And for the record, I want to thank Representative Gray. She knows that I'm not supportive of this bill. I was out sick last week. She could have ran it. And so it was very classy of you, and I appreciate that a lot. We have the gentleman up here a minute ago spoke on this. We have a two-tiered system in our Medicaid program right now. And it's just going to get worse if we keep this private option, private insurance model in place. As the token disabled legislator, I get calls from all over the state. Somebody's found themselves in a situation similar to mine. And they can't go to their PCP 5 miles up the road in their hometown because they're no longer taking traditional Medicaid patients. That young man or that young woman only has traditional Medicaid. They do not qualify for any of these insurance plans. Period. Doesn't happen. They have to wait 2 years at a minimum before they can get on Medicare. And that's happening more and more across our state. The longer that we stay in this, the worse it's going to be. We are, and this is not Representative Gray's fault, it's not Senator Irvin's fault, it's not Ms. Gillespie's fault. It's just the way it is. And you say, well, how do we fix it? Well, I think we could at least level the playing field as far as what we do. We as a legislature do not have the ability to force private entities, doctors' offices, hospitals, anything else, to do anything. I mean, within reason. You understand what I'm saying? But we can quit giving them a two-platform system. We can quit saying, hey, the able-bodied folks, many of whom are not working, I'll say it again, many of whom are not working, are pushed to the front of the line. They have the best insurance. They have better insurance than your school teachers at home that we're paying for. And yet, you take someone in a very vulnerable situation, recent spinal cord injury, recent diagnosis with something else, and they may have to drive an hour just to go to a regular primary care doctor, depending on where they live. That sucks. We shouldn't do that here. And, you know, I've been opposed to the program since 2013. I've been opposed to it since 2012. And I'm willing to say at this point, I give up. I'm done fighting it. Let's just do it fairly, and let's do it the most affordable way possible. The word revenue was used a lot today, and I can tell you who's getting a lot of revenue. And it's a couple of insurance companies and some big hospitals, which I'm fine with the hospitals and doctors' offices making money. But it's not my responsibility as a legislator to help their books. It's my responsibility to do what's fair, what's just, and what makes financial sense for the state of Arkansas. And for that, I would ask that we not vote this out and we consider our other options. Thank you.
Representative Dotson, you're recognized.
Thank you, Mr. Chair. I mean, it's no surprise probably where I'm going to be on this bill. I haven't been lobbied, I don't think. I think I've been asked one time to vote for it by someone. You know, I've been here since 2013 when the private option was passed, when we debated that, went back and forth. You know, this really isn't about expansion any longer. That ship has sailed. We have it. That bill can't be unrung. But we're talking about this particular program moving forward, and as a fiscal conservative, it's not something I can support when we're going to spend $2.9 billion more than an alternative that is available. So this is above and beyond what is required by the ACA, Obamacare, and it's a lot more expensive program, and so I'll be a no. Thank you.
Representative Ferguson, you're recognized.
Yeah, and really this is for Representative Miller. I completely agree with you. I think we ought to pay more in Medicaid fee-for-service. But you have to realize for a hospital or even a practice to sustain themselves, they can only have so many fee-for-service Medicaid patients on their panel. And if you don't pass this and you go to straight fee-for-service in Medicaid expansion, you're actually going to make your access to health care much worse, because then all these people will be in Medicaid fee-for-service, and you won't see it immediately, but you'll start to see doctors close their panels, and particularly specialists who are already hard to see. It will be impossible to get in to see a specialist if you close down this program from insurance reimbursement and put all these people in fee-for-service. It will make it. You think it's hard to see somebody now? Not only will you have hospital closed, but you won't be able to get in a doctor's office.
Representative Bentley, you're recognized.
Thank you, Chairman. I think everybody's time today. I know we're long and tired, and I appreciate everybody's work on this. But I think I heard twice out of Director Gillespie's mail that the people that are on the private option or on the Arkansas homes get to see specialists before those that are on traditional Medicaid. And over again, I hear, as Representative Miller does from my constituents, that they cannot get in to see a physician. We're hurting those that need it the most, and I know everybody's. Anyway, I'm saying I want fee-for-service for everyone and to work on it to make it possible, but to take 300,000 able-bodied people and put them ahead of those that really need it, it hurts me, and I have always been a no. I'll continue to be a no until we work for those that need it the most. Thank you.
All right. Seeing no more discussion, no more comments, the motion is do pass. All in favor signify by saying aye. Aye. All opposed, nay. No. Ayes have it. Call the roll.
Representative Wardlaw.
Aye.
Representative Eubanks.
Yes.
Representative McGee.
Yes.
Representative Dodson.
No.
No. Representative Miller.
No.
Representative Payton.
No.
Representative Bentley.
No.
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 Representative Gray.
Yes.
Representative Gonzalez.
No.
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 Representative Boyd.
Yes.
Representative Allen.
Yes.
Representative Coleman.
Yes.
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 Representative Pilkington. Representative Pilkington. Representative Wing.
Yes.
Representative Penzo.
No.
Representative Perry. Yes. Representative Davis. Representative Davis. Vice Chair Ferguson.
Yes.
Chair Ladyman.
Yes.
It's 11.
Oh, you missed Cloud.
What?
You missed Representative Cloud.
Oh, I'm sorry. Representative Cloud. I'm still here. I'm sorry?
We thought you.
No.
Motion passes. Congratulations, your bill is passed. Committee, looks like we're done, committee. I want to thank you all for coming back. We had 19 people come back. I really, really appreciate that. Y'all done a lot of good work. We are adjourned.